Alrighty, well, I don't know what was more exciting, being added to this project or speaking right before lunch, but either way, it's a little intimidating, so you guys hang with us and we'll be fairly brief. Ours is very similar to what we've already heard. We knew it would be that way, just talking to our friends, and so I'm just going to get started. My name's Karla Lamb. I am the PostAcute Director of Case Management in the Referral Center, so I get the exciting opportunity to work with lots of folks. So, just a quick organizational overview for our home care. We are hospital-based. We're a certified home health agency. We are one county, so we've been serving in Spartanburg County for 30 years. You can read our stats there. We have nursing, PT, OT, speech therapy, master's in social work, AIDS, infusion therapy, telehealth. We're really proud of our certified wound nurse. We have a team that we're working toward. They're doing a phenomenal job. We have behavioral health nursing and chronic disease management. And we have a few other programs that we're really excited about. And since Dr. Snipes leaned over and said, you should tell them a little about Impact, I will. We have an Impact program in Spartanburg. We have a lot of folks who do not have primary care providers, and so we have worked with nurse practitioners and physicians actually going out to the home. So we do not turn patients away if they do not have a primary care provider. And we have partnerships with 12 assisted living facilities and 4 independent living facilities, and then our average daily census is right at 500 for our home care. Our challenges of this project, I kept it short. You can see our process map, so we have plenty of challenges. But our challenge was identifying a standard process. What we thought was standard really was not standard when we started really pulling out and seeing how many hands was in the pot and then the why of the rework. It was amazing. Another challenging part of this project, it was exciting. I had the opportunity to go on to the listening tour. But it was a challenge sitting there listening to physicians talk about their perception of what we were asking for them and how our competitors were asking the same sort of thing and what they were doing. That was a real challenge. And then the last challenge was really embracing the barriers and what do you do with all of them. So that was a challenge as well. Our team members, I have a lot more that I could add on there, but basically we embraced the project wholeheartedly, even though we were the last add-on, and I guess that's why we got the before lunch spot, right? But we basically, every person that owns or has any part of our home care agency was there, from the vice president to our medical director. Dr. Snipes was fully engaged, which made things really interesting. And Phyllis Osborne, who's the director of our home care agency, Linda Edmonds, she's our population health manager. Jill Green, she's the post-acute chief nursing officer. Patricia Steinmack, myself, Sherry Eisen, Leslie Wolf, Odette Ray, Vicki State. We had compliance. We had everybody that could possibly touch the home health. And I didn't even add all the hospitalists we met with and still are meeting with, and physician practices, anybody that touched home health. We just included them, and it was a great time, even down to billing and health informatics, which was also quite interesting of what they expected from us. So. This is our team hard at work one afternoon. Here, actually, we were reviewing the process state map, and it took us a little while to get a picture because some of the pictures, Linda Evans said, you can't include that picture. We were all holding our heads like, what has just happened here? But this is probably one of the better ones. And this is our baseline map. It is, of course, taped up there. You can see plenty of pink, and so... Our barriers, though, we have a lot of barriers, but we just wanted to highlight a few, and you'll be glad because you're going to lunch soon. So the main one was the physician knowledge related to face-to-face requirements. That was like the cropping that continually repeated itself. And physicians that we've met with did not understand the goals or what they had to document, and it really was malaligned with what we needed. We also needed a contact lead for physician practices and hospitals. I've heard everyone talk about a sales team In Spartanburg, we do not have a sales team. And so we have kind of created our own sales team, which is actually the frontline clinical leaders for our agency. We do not employ folks who go out and gain business. The people they're dealing with is the frontline staff. And so that is one change we made rapidly as we were going through this process. And that ties into a little bit of the intake process. I heard one of the pilots talk about the nurses or the intake folks. We took some of our nurses that was actually sitting in the referral office and actually placed them out in the field taking care of some of those other things. So, and we had extensive process change. When you talk about solving the world's problems in healthcare through one pilot, that's kind of what we felt like we were doing, and we dissected our agency slowly and trying to align more efficiency there. And one of the barriers really is time allotment to role change. We have a lot going on in our home care agency, as I'm sure you all do, and we also have the opportunity to go up on Epic this year. So, well, actually, it'll be live, I think, October, but the build's complete by December. So we're all having lots of fun and more responsibility than we can handle. And so time allotment is a huge challenge to role change the whole organization. We did another barrier that we had was the dedicated start of care review and really creating a standard process for that. And then the last thing, because I've already mentioned Epic, is our fax line. We thought we had a very efficient fax line. It actually is huge, and it is tied to when it was originally designed. It was designed to receive 42 faxes at one time, and we assumed that they were all coming through. And what we found out during our listening tours, everybody's getting a busy signal. And so then we went through really pulling back, why is that happening? And as an organization, they had added more users onto that fax line, which included physician offices and the hospital. And I'm like, so if they get 40 faxes at a time, will it give it a busy signal? And they said, yes. And I'm just looking like, wow, because we started testing it and we were in fact getting a busy signal. So that was a huge barrier to our organization. This is our future state map, one we're very proud of. We are a late bloomer in this project, but we are rapidly moving forward under the terrific clinical leadership of the home care agency for our future state map. We may be a late bloomer, but we've made a lot of progress here. And then our initiatives list, I just brought out a few of those. We had a good number. We'll just keep it to ourselves, of the number. But what our initiatives we just wanted to really tackle initially was develop and implement physician education and tie it to a CME offering so they wouldn't look down at their phones or they wouldn't be so disengaged, and they'd be really willing to listen to us, and so that we could provide regular education to them. Redesign and standardize the intake process. I know that seems like, wow, do you not already have that? We had a great intake process. We have great people that work for our home care agency, but really being able to map out that standard process was a challenge. To develop and implement the start of care and weekly case review, and develop physician practice lead, and develop a cross-functional team to own the face-to-face and plan of care certification. Vicki State is our compliance officer, and I know you had mentioned the compliance officer owned the face-to-face, and it was a challenge. Everything that happened beforehand was what was making it so challenging for her to really own it. And so a cross-functional team now owns that face-to-face. And we wanted to ensure uniform computer access for all staff. I kind of giggle when I say that out loud because when people were coming into the room, they'd say, oh, I don't have access to that. And we were all like, really? Because nobody knew that before. So those are things that we've kind of taken care of. And so with that, Dr. Snipes, our medical director, is going to talk about one of our initiatives instead of a broad variety of the physician education.
Thank you, Karla. Well, full disclosure, first of all, my main job really, I'm the hospice guy for the system. We have a companion hospice agency, inpatient hospice unit, so I actually spend most of my time doing that. But I really am the medical director of this agency. I think it's the first time I've heard that word mentioned today, actually, medical director, because as you all know better than I, a physician medical director in a home health agency is practically useless. There's no requirement for one. There's no defined role in complete distinction to hospice. There's no defined role for a hospice medical director. So mostly I'm invisible. I attend meetings when they invite me. I answer questions when I'm asked, which is rarely. But occasionally, Karla trots me out to talk to doctors. And so this was one of those situations where I was asked to do that. So I am going to describe this physician education initiative that I was asked to assist putting together and to do most of the presenting. We have a very physician-centric system, I'd have to say. And physicians like to hear from physicians. It seems to mean something. That may be the case everywhere, I don't know, but I know that's the way ours is still. So that was the reason why I was pretty heavily involved in this. So I participated actually in part of the listening tour. I guess the listening tour was part of this whole process, but I did participate in some of it, not all of it. I did meet personally with the hospitalist group leadership and the primary care physician leadership. Our system owns, of course, many physicians. And I met with the leadership of those just to hear what they felt their needs were, what their perceptions were of our agency, and how we could most effectively work with them. And we did learn a lot. It was really very informative to do that. I mean, what we learned was that while they like our agency and they think we do good work, they were not entirely satisfied with the intake process. They thought it was cumbersome and redundant, and and the forms being shredded. That's common, I think, in our system, or at least it was up to that point, because they just didn't understand why they were getting all the requests for information. Mostly, they just didn't get really home health. I mean, surprisingly enough. And in my former career, I was a primary care physician for many years. I don't remember not getting home health, but I don't remember thinking about it too much either, to be honest with you. But they really just didn't get home health. They didn't get a lot of the terminology associated with home health, and therefore they didn't really understand what was being asked of them as far as certifying someone for home health services and documenting that certification. So based on that feedback, we designed an initiative. We decided that we should go where the docs were. Inviting physicians to a dinner about home health was going to be a loser, even though they might get dinner. It was going to be a loser. They weren't going to show up for that. So we actually go where they are. We go to the hospitalist meetings. Actually, we're just getting started because we were the last guys on the list, I think, for this initiative. So we're just getting started. But the initiative is planned, and by the way, we've had really good receptivity among our physician practices to us doing this. So they're eager for us to do it. The holdup is we decided to get CME credit for this, and of course we have a CME department in our system, and working through that's taken a little longer than we thought it was going to, but we're almost there. So what we're doing is going to the groups, and we've been to the hospitalist groups already, but going to the groups and providing CME accredited information about home health, some clinical information, some procedural information about home health. So the components of the presentation were as follows. We decided, and I guess I should say I decided, that it would be good to try to engage the physicians in home health at a level that at the level of their self-interest, to be perfectly honest about it. I mean, physicians don't completely understand why they should even care about home health that much. A lot of docs don't, particularly hospitalists. I mean, the hospitalists take care of the patient in the hospital. They do a great job there. When they leave the hospital, they're gone. I mean, out of sight, out of mind. And I won't say they don't care about it. They just don't feel like they have an interest in it. So we decided to sort of step back and take a little higher view and paint a picture for them of how important home health is now and is going to be extremely important to them going forward as our healthcare system evolves. Now, that's the big system, not our system. It'll go right along with it, of course. And then we get into some of the details on home health eligibility and certification, and we hope this will sort of bond the relationship with our referring physicians, not all of whom are actually part of our system. We, of course, have physicians in the community that are not part of our system, and we receive referrals from them. So we hope that will, I guess, result in what you might call referral development. I'm not going to give the presentation to you, but this is the title slide. We called it, what did we call it? Your Regional Home Health, your new best friend in the management of complex patients. So first of all was to talk about the role of home health in a changing healthcare system. And again, this was to give the physicians a stake in it. William Gibson is a science fiction writer, and he has a quote that I love and use a lot, and that is, "The future is now, but it's not evenly distributed." And that's true. I mean, the South Carolina market is probably relatively behind the rest of the country as far as what I'll call payment reform or volume to value or whatever you want to call it. So a lot of our physicians just don't get that. They really don't, surprisingly, really don't completely know what's coming their way. More importantly, and I had this impression, it was sort of confirmed in a study that came out in the academic family practice literature a couple of weeks ago. Actually, only a tiny, tiny percentage of physicians' compensation at this point is tied to actual creation of value or quality, 2 or 3%. Even in ACOs, it's still minuscule. So doctors don't really think in terms of value. They're still thinking in terms of being piece workers and cranking out patients and not worrying that much about what's going on in the rest of the system. So we tried to paint a picture for them of how that might look and how post-acute in general, services and home health in particular is going to fit in. So we talked about volume to value. And again, this is in fact new information for a lot of the physicians that we work with. The hospitalists, let me see a show of hands. How many of you are familiar with the Medicare spending per beneficiary metric? So a few of you are. Well, talking to the hospitalists, I mean, it amazed me to learn that a lot of them had never heard the Medicare spending per beneficiary metric. Now, this is a metric. It's actually, I think it's one of the classified under the category of an alternative payment methodology. It's part of the value-based payment that hospitals are subjected to. It's a withhold. And the Medicare spending per beneficiary calculates the average cost over the country and sets a target for how much that should be for a few days before the hospital stay to, 60 days after, I think it is. I can't remember the exact number. It's about 60 days. What is it? 30 days after. Okay, so 3 days before and 30 days after, I think it is. And the hospital, if its Medicare spending is above that preset target, then it doesn't receive part of the withhold that they do for the value-based purchasing. This will actually account for 25% of that withhold in 2016, as of 2016. And the hospitalists are going to own that metric as far as I can tell. They're the ones who are going to be largely in control of those costs in the hospital, and the post-acute costs are part of it. So hospitalists will in fact have an interest in home health. That's just an example of the way that our fortunes as physicians are going to be tied to post-acute services and home health in particular. I also talk about the fact that the most cost-effective, highest value post-acute entity is home health, and there's certainly data to support that. Continuing in that theme, I share a little bit of information about where patients go for post-acute care. Actually, S&F is above home health now, and that's expected to flip in the next few years simply because of the cost pressures. Physicians aren't really aware at all that health outcomes are only about 10% tied to the medical care they receive. 90% of the health outcomes are social determinants, and home health agencies actually address social determinants. And we're going to have to become accustomed to thinking about those social determinants as time goes on. So I do point that out. Most home health agencies, ours included, are developing models of care for what would be considered to be high-risk patients based on risk stratification. And so I point out that our agency is involved in that, and we will have special models of care to deal with clinically complex patients. All of this, of course, is geared towards achieving the triple aim: better individual experience of care, healthier populations at reduced cost. So after painting kind of the bigger picture, then we get into the details on home health eligibility. The word homebound, good Lord, it is so confusing. I mean, in natural language, it would seem to mean the patient's literally bound to the home or confined to the home. And of course, it doesn't mean that. But to a physician, that's just a complete mystery. It's like we're talking Chinese. So we talk about homebound status, what that really means, the other requirements for home health eligibility, having a following physician and skilled need and so on, and a bit about the face-to-face encounter requirements. Although I leave a lot of the details up to our other folks, but I do talk about it some, and somehow me saying it seems to make a difference to them. So our physicians like pocket cards, oddly enough. They like especially the hospitalists, but even the office-based physicians like these little pocket cards. So they asked to have a pocket card that would summarize very, very succinctly what we want them to do to document eligibility and how to get eligibility for their patients. And so, by golly, we created a pocket card. We've got some of them here, don't we? Yeah, we got some, and I think you can probably got enough copies for almost everybody. And so what we put on the pocket card, we sort of, I guess, focus group Dr. Feliciano's 4-question. I love Dr. Feliciano's 4-question model. I have for a long time. I mean, I'm a geriatrician too, so it's a great way to look at clinical problems. But the physicians, it clicked with our physicians that we talked to about it. So we actually put the 4 questions on our pocket card. And I'm not going to say the 4 questions, they've already been said, but they're really a great way to think about patients and how to figure out what they need and figure out and document that in a way that's valid and actually does establish eligibility. So we are providing these pocket cards to the physicians as we go see them. There's the front and the back. So the goal of this, of course, was to help smooth this process out. We have future initiatives. First, we're going to make the first round, and we're actually planning to continue this. I can make 1 or 2 of these presentations a month at the physician offices and in the practices. So we're going to continue these, continue providing CME, and do these as combination of clinical and updates on regulatory information for them. We actually have in our home health agency, in our post-acute division, actually, a population health manager. It's Linda, hold your hand up. Linda Edmonds. Linda Edmonds. She's our population health manager. She's a terrific physician practice liaison. She actually managed a large group of internists in the community before she came with us. So we have her out there. As Karla said, we don't actually do marketing at the regional system. It's just not part of the culture, but she's out there serving as a great practice liaison, providing information. And then we have a whole post-acute navigator team, referral team that serves as consultant and navigators to get people into the right post-acute venue. And so these are continuing educational initiatives that we think will sustain this initial round of education that we're doing. So what do we hope to achieve by this? Well, first of all, we want to get our patients, the patients that we serve, the best possible home health care. When all this energy is expended in doing things over and over again and not getting it right the first time, that's taken away from, there's only so much energy to go around, so that's taken away from something, and I'm afraid it's sometimes taken away from patient care, which is really what this is all about. So happy patients is the first objective. We would also like happy docs. I mean, that would be nice. And so having a smooth, clean referral process that they can understand and not feel like that they're being abused or asked to do things over and over again is the second objective. And the third objective is we like our billers and business people to be happy, and most of all, we want Palmetto GBA to be happy. Not to suck up or anything, but we really do. So these are our objectives, and although we're just getting started, we made a couple of these presentations to start with. They've been well received. I think it's going to go very well. So with that, I'm going to turn it back over to Karla, and she's going to bring it on home.
So our control plan metrics, he's a little taller than me. We were looking at our percent of clean referrals on admission, our percent of clean claims accepted on initial submission, and our percent of billing error edits due to face-to-face needs. And we are following that. Like I said, we're really early in this project. We really just wanted to get our feet on the ground and start some initial physician education, since we felt like that was going to be the number one impact for our organization. Our lessons learned and processes benefited looks a lot like a lot of the folks that have already presented, but we have definitely learned physicians do not understand in our area the role of home health, or how it will help them and how it will help impact their patient satisfaction and how we can really help them in the community. They do not understand the home health eligibility. The homebound is like a big hang up in our area. The home health certification requirements are also cloudy in our area. And then for us, Linda Evans and I were talking one afternoon, and I think Jill and Patricia, some of those were there, and just work and rework prevents valuable work. I mean, and that is like the summary. If there was any statement in our whole presentation, we did a lot of rework, but the outcome was still the same. Until we made a change in how we were going to approach it, we were still coming up to the same end. And so we've really streamlined and developed a really cross-functional workflow and a team approach, which has been great for our organization. We had no idea how many silos we potentially had in the office. And our supply chain message, what I've learned in the physician offices, which has been a challenge for me to hear, is home health regulatory requirements are challenging, and they really can be prohibitive to patient referrals. Sometimes we have a large portion of patients who really would benefit from home health, but the physicians do not want to jump through the hoops of ensuring certification. And as healthcare providers, we're all here to make sure that we care for our community and our patients, and we really want to be paid, and we want to prevent the readmissions to the hospital, and we want to partner with the physicians. But overcoming the leap of how we are, the regulatory part, we don't want it to be prohibitive to patient care. And so that is with the face-to-face documentation and how we were handing back certifications and the physician orders. And so that's all I have.
Questions? Okay.
Doctor, the one new thing that I heard that I'm intrigued by, because I had some experience with it in Pennsylvania, was the idea of doing a CME to entice or engage physicians and actually hearing it directly from a doctor. A, has that been effective? And B, is there anything we can do at Palmetto to help enhance that, maybe even globalize and standardize that? I don't know, Harry, what the process would be for us to get some of our education become CME certified, whatever that law is. But we'd love to engage in that process. If the docs around here are like in Pennsylvania, they want to hear from another doc, they get that CME credit.
That is the case in our system. They seem to appreciate hearing it from another physician. And CME is attractive. I mean, it's expensive now. And so providing an hour of CME periodically, it is sort of enticing to physicians. I mean, it will engage them more than not offering that. We're part of a system that's large enough. We're a teaching hospital, and we're large enough to have a CME department. It's pretty involved now to get CME credit, but we're working through it, and I think we're okay as far as getting the credit. We're just getting started with it. We went ahead and did some of these prior to actually getting the CME, so that the presentations are going well. I think having the CME will be an additional added benefit.
Is that limited to your system or your region, or is this something that you hope to break out?
Right now, just our system, yeah.
So Harry, that's why I'd like you to, if we could figure something out there, I think that's something I'd like to pursue. No, I put you on the spot, but.
No, not at all.
He's used to that.
No, I don't see it as on the spot. One of the things that as a partner in education, we usually ask a sponsoring agency, like say a university or an association, and if as part of this outcomes of this project, if there are opportunities to partner with hospital systems, with physician associations, and make those CME credits available and have us be part of that, we would welcome that.
Thank you.